Of talk is here. Power 102 Digital.
Indeed, it is right here at Power 102 Digital Wednesday. Hot Talk starts now with host Fareed Ali. Good afternoon, Fareed. You may introduce your guest.
Good afternoon. It's good to hear your voice. How's everything going?
I'm cool, normal as ever.
Well, to the listening public, we have no other than Dr. Joel David T. joining us this afternoon. If you all out there have been following the series that we started a few weeks ago, this is our fourth week in touching and perhaps, let's say, dealing with the issue of diabetes and its consequences. So previously we would have had some other doctors, and today we have Dr. T. Sharing his views and sharing his wisdom and his knowledge with us. Dr. T. Thank you so much for your availability and your warmth in making yourself available to us here this afternoon. We really appreciate your presence. Thank you.
You are most welcome. So it is an honor and a privilege to be a part of your team here at 102 FM.
Thanks so much. The public don't want to hear my voice. They want to hear yours. So let's go straight into where we are. I was reading that obesity is, let me quote here then, rather than I try to interpret what's for me. I was looking at some articles in the newspaper, The Express, Monday the 17th of May 2021. So it's a dated article, but I was looking at the issue of obesity. It says here, and I'm quoting in the third paragraph in an article written by a reporter, Kimberly Wallace. It was talking about, she was carrying the dialogue on obesity. It says here, obesity, which is a body mass index of 30 or higher, is a complex condition because the cells that store fat is also an endocrine organ and serves many functions normally, which can become disrupted when someone is obese. That is all gibberish to a lay person like myself, and one would imagine the public listening would want to know what is body mass index and how do you all calibrate, you all as doctors, calibrate body mass index. So me, when I hear the word obese, I think a big fat person.
Yes.
So what exactly is obesity in the medical context?
Thank you very much. And once more, if I may congratulate you and the rest of your team for driving this knowledge towards enhancing health in Trinidad and Tobago, because knowledge is power, particularly when it comes to prevention. And if you think about this scourge, a mounting pandemic of increasing body weight, you have fat around the tummy, which is sometimes used as a marker towards driving someone's risk of high blood sugar, high blood pressure, your cholesterol, your risk for having a heart attack or stroke. That abdominal fat is one of the markers. The body mass index, or that excessive fat, is sometimes used as a gauge to determine if somebody is struggling with their weight. You might be overweight, you may be obese, or you may be super obese. So you have some terms which are often used, including morbidly obese. Now, the body mass index is simply a ratio that looks at the person's weight in kilograms divided by their height in meters squared. So you have to have two bits of information as part of the clinical examination. So when you go to a doctor and he or she is trying to take a history and do a physical examination, they're looking at your height and they're divided by your weight in meters squared. So that's squared. And that ratio is, the writer of that article is saying that if that ratio exceeds 30, you'd be classed as obese. You're overweight if that ratio exceeds 25. You might also be interested to know that Trinidad and Tobago has one of the highest incidents of obesity in the world per population. In fact, we are ranking in the top 5, Trinidad and Tobago, in a nation that is just exceeding 1.4 million people. Think about obesity as the driver of a car, and you look into the rearview mirror, and you're seeing that plethora of complications. We mentioned some a bit earlier, high blood sugar, your pressure, your cholesterol, but also there are others, gallstones, joint problems, including joint inflammation. Some young girls are having polycystic ovaries. They're having irregular periods, excessive hair growth. They're having acne and problems to conceive. There are patients with non-alcoholic fatty livers. There's a rise in cancer, all linked to obesity. So it's a frightening scourge and indeed an exploding pandemic. Now, we used to think that fat was merely a storage organ. It's something that would be a reflection of affluence in the society. Perhaps you don't want to balance your child or your grandchild on your abdomen, that you've done well. But what we know that these fat cells are angry and exploding. They're producing a host of inflammatory substances. So the word endocrine, and that is part of my specialty, the word endocrine refers to hormones, the study of hormones. And these are messengers which are produced by glands. They are transported, usually in the bloodstream, and exhibit effects on different target organs. That's what a hormone is. And fat cells produce a large variety of hormones, and these increase inflammation in the body. Now, those risk factors like diabetes, hypertension, your cholesterol, and smoking, those risk factors create a toxic milieu or an environment that cause the formation of plaque in your arteries and increase the chance subsequently of having a heart attack or stroke. So it's one thing to just talk about numbers when we're talking about the body mass index, whether you're measuring obesity, perhaps you do a finger stick check on your sugar, or you measure your blood pressure at your doctor's office or in the pharmacy. It's one thing to talk about numbers, but at the end of the day, the watchword is prevention. We don't want the complications that come with these chronic diseases. You don't want to end up in a hospital bed or worse. You don't want to have a heart attack or stroke in which you're debilitated and your lifespan has been shortened. That's why it's important to not just assess your risk for having increasing weight, but also to look at some of these complications and ensure that you go for regular screening.
I was reading where, according to the panorama of food and nutritional safety, we had a 6%, in 1975, we had a 6% ratio in the population in terms of obesity in the population. And then they're saying that by 2019, adult obesity in the region rose to as much from 6% in 1975 to 25% in 2019.
Shocking stats, Fareed. Yes.
My thing is, like everything else, to me, education and detection that assists in terms of alerting us to what needs to be done. Without detection and without education, in terms of the knowledge how to treat with your condition, you struggle to cope with whatever ailments you have. Meaning, if it is you have a diabetic condition already, or you're pre-diabetic, without that detection and education, you can't fight the condition that you have. For persons like myself, I came through that era when I went to primary school, secondary school, and there wasn't any literature. Social media hadn't taken its root as yet.
Yes.
So now that information meets you regularly and momentarily in seconds at your doorstep. So persons like myself who are in our late 40s, our position would be, I'm not creating excuses, I'm just saying that generally, we would not have had the benefit of what the young persons have now and the information at your fingertips. I grew up when I felt ill and sufficiently ill that I can't cope with it anymore. I go by the doctor.
Yes.
So I try to fight it at home with my own, if I may put
remedies.
Remedies. And then when I realized I can't do this thing anymore, I could turn to the doctor. What is your take on, in terms of, you explained how you calculate the body mass index. How do we treat with obesity in its most basic form? How do we confront that issue?
Yes, that too is an excellent question. And I want to indeed endorse your insightful observations that perhaps 30 to 40 years ago, there was a dearth of medical information and literature that could be accrued about battling some of these chronic illnesses. And indeed, many people presented to hospital in the latter stages, often with devastating effects. Because if you look at something like diabetes, I mean, we know that this is a frightening scourge in the world. You have almost 500 million people in the world with diabetes. It's a leading cause for end-stage kidney damage, a leading cause for blindness among working-aged persons like ourselves. The number one reason for non-traumatic loss of limbs. You're 2 to 3 times more likely to have a heart attack and stroke if you're a person with diabetes. And many people would not present to hospital for care, for monitoring, for medications. But unfortunately, and this is where we could think about the impact on something like your healthcare budget and the impact on a country's economy is going to be under pressure, is going to be stressed because of these complications. So we've been struggling in terms of helping primary care and prevent these problems. So your question about obesity and dealing with the root cause and the underlying issues with inflammation and the consequences or the sequelae of obesity is a very valid one. Now, it would be simplistic to think that somebody who has increased body weight is just struggling with an improper diet or sedentary lifestyle, a lack of exercise. That's a simplistic approach because obesity is a complex genetic, environmental, socioeconomic, cultural, even psychological disease. So it has been recognized that obesity is a separate disease entity. We mentioned that fat cells are producing a plethora of hormones, and these create inflammation in the body that lead to all of these chronic diseases that we discussed, or many of these problems that patients battle. Now, of course, the first stage is towards prevention, a healthy diet, returning to that sort of diet from the 1950s and 60s of Trinidad and Tobago, a diet rich in fruits, vegetables, nuts, peas and beans, low fat and low salt. We have actually learned to be fat over these last few decades. We have substituted machines for muscles. We have started eating more energy-dense or calorie-dense, high-fat foods, which are increasing our body weights. So, and as a result, this explosion of social media, persons now are spending more time indoors, and this has been exacerbated since the start of the COVID-19 pandemic. Persons are more sedentary. We are seeing this in children. So children are not being active anymore for whatever reason, whether it's stress at school, whether it's the need to compete at different levels of academia. Children are afraid to go outside. That might be one of the issues associated with crime and its impact on public health. You may not have enough green spaces as there is a trend towards increasing buildings and urbanization in the country. So there are many socioeconomic problems. There are many genetic, hormonal, psychological issues that increase body weight. So trying to get a healthy diet, trying to improve your level of physical activity, whether it's 30 to 60 minutes for most days in the week, whether you're running, walking, jogging, biking, you can try to include that as part of your daily activity. So if you use the staircase instead of an elevator or an escalator, if you try to park your car a certain distance away from your office building, so I hope you find your car when you go back for it. And let us say that you are trying to include some sort of physical activity during the course of your day, 30 to 60 minutes to reduce this impact of increasing body weight. If you're having psychological stress or lack of sleep, these are factors that you'd want to chat with your physician about. Some patients have found that since COVID-19, there have been shadow or parallel pandemics of depression and anxiety, and that impacts on body weight. Persons are having problems sleeping, they have a reduced appetite, they have feelings of hopelessness, helplessness, and worthlessness. They're having reduced self-esteem, a low mood. Those create inflammatory substances, and also hormones that increase body weight, like steroids or adrenaline. They increase body weight, increase your blood sugar and your blood pressure, and leading to devastating effects. So the answer towards how we're going to address obesity is not a simple one. It's a multifaceted reply. It involves dealing with risk factors towards obesity, involves changing our lifestyle in terms of these intensive lifestyle interventions to increase physical activity and improve our diets, staying away from fatty foods, foods high in sugar and those high in salt, and also looking at someone's mental state, improvement in mental state. So it has been said that that is becoming an enormous burden, and perhaps it could reflect one of your future episodes as we talk about improving health in the nation. There are some medications that also increase weight loss, so you'd want to have a chat with your doctor about them, because these have been quite popular on social media now, including among stars in Hollywood. So they have carved a niche because they were initially meant for the obese type 2 diabetic patient, but they have found a niche in the management of weight loss. So Ozempic is one of the brand names that you may have read about or heard on social media. And as we go further and someone's risk factors for having a heart attack and stroke increase, they're battling with their body weight, they have a very high body mass index, it becomes difficult to incorporate purely lifestyle interventions. They may need to discuss medications with their doctor, and you may even want to consider going into the realm of surgery. There is a type of operation that falls under the umbrella term of bariatric surgery. And some of our listeners would have heard about a gastric bypass as one of the tools in the armamentarium to battle obesity. So it's a complex disease with multiple facets, multiple causes, different modes of management. And you would want to have a chat with your doctor, not about just screening for complications, but also what would be the next best tool to address this illness.
I was reading where it has been said that 40 million deaths occur each year as a result of non-communicable diseases such as diabetes. I read in another article that in Trinidad and Tobago we lost 2,000 lives due to the COVID pandemic, or as a result of the COVID pandemic. And much was said about that. But what we're not mindful of, that we lose 6,000 people yearly as a result of complications arising from non-communicable diseases such as diabetes. So in as much as, in keeping with what you're saying, it seems clearly that we have, for whatever reason, we have downplayed the effect of non-communicable diseases on some level. I mean, doctors like yourself and the literature that is in the public space now speaks otherwise, but I'm saying so much has been said about COVID-19 and the loss of the 2,000 lives that we haven't been mindful that there's a greater killer out there, which is non-communicable diseases. My question is this. I've also read that diet and exercise is so important, and it helps increase blood flow, it helps with one's breathing, it helps with physical fitness, and physical fitness allows us to cope with conditions better, and it empowers us. But the information out there can be so conflicting. Like everything else, one ought to embark on this drive to be more physically fit with some level of discretion. One doctor indicated that before you start putting your body through strenuous exercise or even moderate exercise, one ought to have oneself checked out medically to determine how much pressure you can put. I'm using the word pressure purely from a lay perspective. What is your take on that in terms of, yes, the public is listening to you about diet and about exercise being necessary, but I don't want people out there to go wild on exercise now and say, well, we can eat as much as we want and we will sweat it out with exercise. Just walk us through that process of your recommendation with regard to diet and exercise, how to manage that, where's the balance?
Thank you. It's a good question, because it would just be highlighting that there is a multi-pronged approach to intensive lifestyle changes. The watchword is indeed prevention, and we could talk about the value of exercise. It doesn't just lower your blood sugar, your blood pressure, your cholesterol. It doesn't just lower your risk for having a heart attack and stroke. It reduces your chance for cancer. It improves your mood. We spoke about the impact of psychological issues since the start of the pandemic. So, and if I may add that the Ministry of Health stats are actually as high as 4,500 deaths since the start of the COVID-19 pandemic. So psychological boosts. So as a result of exercise, your bones are stronger. So there's a reduced risk for having brittle bones that many of our post-menopausal women in particular would find themselves at an elevated risk for. So there is a plethora of positive effects to be accrued from having regular physical activity. Now, any sort of physical activity is better than none. And in fact, it's been said that perhaps many of these chronic illnesses are due to sitting for too long, sitting diseases, that perhaps once every hour I'm in an office, you may want to consider, so even if you take a walk for a few minutes, just to improve your level of fitness, any type of physical activity. The faster that you go and the brisk and the increased speed at which you may find yourself walking, running, or jogging would be dependent on many factors, including perhaps the state of your joints or the state of your heart health. You would definitely want to liaise with your primary care doctor or a heart specialist if you're unclear before embarking on any vigorous fitness activity. And of course, if you're in a gym, there are usually warnings on many of these treadmills or machines which involve fitness, saying that if you're having chest pain, shortness of breath, if you're dizzy or feel to faint, you should discontinue doing that exercise, rest, and contact your physician. So those are red flags, those symptoms. But some patients have been known to, unfortunately, go out to a football field or engage in some type of vigorous physical activity, and they run into complications on that said field, sometimes with tragic effects and tragic consequences. So have a chat with your doctor if you're worried about engaging in anything, because there may have been silent diseases which have been developing. So that's the role for screening. We discussed that a few years ago. Perhaps we would not emphasize that. We would wait for a problem. Now the watchword is prevention. And we've moved towards that term called primary prevention, ensuring that you prevent illness before it occurs, and looking at risk factors such as diabetes, hypertension, and so forth to ensure that they're properly managed and at the end of the day, prevent the formation of plaque in the arteries and then that dreaded term, inflammation in your body.
There's a developing trend in Trinidad and Tobago where I noticed that in communities, in the parks and in designated areas, we have what we call food courts. Let me say that in a different way. When we drive around that savannah in Port of Spain, there's in that area of the south of the savannah, closer to the Memorial Park, there's a huge food court there, and that's what we call local food, street food. In Trinidad and Tobago, everywhere you go, somebody selling barbecue by a corner, boiled corn.
Too many temptations for you, Fareed. Yes.
Blood pudding, everything you could think about.
Yes.
But when this is encouraged, I'm not saying that this shouldn't be. I'm just saying that traditionally, the way we conduct our affairs here and the way we live in Trinidad and Tobago, there's a lot of access, easy access to food that we can't tell what's the calorie intake and what's the calorie count. We can't tell what is contained in that. We just know it's smelling good and it's tasting good. So in as much as you're encouraging persons to eat healthy, when we have these temptations that present themselves on every street corner, and sometimes it's state sponsored, because the the conglomeration of persons selling at that southern part of the savannah, I'm not pounding them in a manner of speaking. I'm just saying that that's the one that's very visible. There's a efflorescing of similar ones in the east, by the Tabarigua Savannah, in Arima, and it's trending. So
San Fernando by the Cross, yes.
good. So my thing is, one would imagine that doctors like yourself would discourage persons from partaking and buying food in these areas, because you can't, there's nothing on any of these boxes that says how much processed this is in it, how much processed that, how much sugar, what the ingredients are, what the condiments are. So, and there's a new thing, well, there's an old thing that is always there. If you're a fruit punch man, or you're into punches on the whole, there's a juice man that's selling a bomb mixed with all kind of peanut and banana and strawberry and raspberry. And my thing is, when I buy these things, it tastes real good, but you're discouraging me now with what you're talking about.
Well, it's a super point that you're mentioning, that the ease of access for high calorie, high fat, sugary foods is something that is part of the modern world. And it's a return, as we discussed earlier, to a simpler time. And unfortunately, unhealthy foods are often readily accessible. They're sometimes cheaper than healthy ones. And they're sometimes very quick options for working single parents to actually take home to children. So once more, from a socio-economic and cultural standpoint, it becomes difficult to battle the rising trend of obesity because healthy foods are often ridiculed or are often stigmatized because of the fact that they're too expensive, and persons are often afraid about the pesticides and the chemicals that may come as part and parcel of these fruits and vegetables that could be purchased in a market. So the ease of access of calorie-dense or so-called junk food is something that has become a global trend. However, what we should incorporate in Trinidad and Tobago, and you mentioned it, is perhaps enhanced knowledge about labels and the value of food labeling. Teach your children to start reading the number of calories, your content in terms of saturated fat, sugar, salt, or sodium, because these are some of the components that are going to drive chronic disease. And would you believe in restaurants or in places of the world like the United Kingdom, there is a traffic light system when you go to buy meals, such as ready meals, or if you go to a restaurant. The number of calories would be listed at the menu. So if you're having a meal, you have your number of calories, or to make it easy, if you're skimming through a menu or if you're in the supermarket, that traffic light system is printed on the packet, in that green means that it's healthy, and a yellow or an amber color means that you have to be vigilant, and a red color means that this is high in sugar, salt, or saturated fat and is likely to have negative health consequences. So green, amber, and yellow as part of a quick skim. So if you're skimming the label, you will get a quick idea as to whether this is healthy for you. The other change that perhaps we should consider locally is whether we want to keep soft drinks at affordable prices. They have tried enhancing taxes in sugary drinks, or sugar sweetened beverages is the term, because we will include some of the sweetened drinks that you mentioned, whether you're looking at a locally made punch, which is laced with a high concentration of sucrose or table sugar, or you're looking at some of the fruit juices with very little fruit, but a lot of water and sugar more than anything else, that we want to enhance taxation on these beverages because that has been proven to work in different countries of the world. Now, it requires intervention from the government, all the stakeholders involved, whether the Diabetes Association, the government, the media, and all of the medical or nursing associations in the country have to understand that this battle is a very difficult one, because it involves going against sometimes conglomerates which are interested in the bottom line. And we know when it comes to business what that is. So when we're thinking about health, it might be easy to access. It may enhance your palate. It's something that you enjoy, but it's something perhaps to be done in moderation and to be sampled in moderation despite the availability. And we'd want to move away to a simpler time, a time perhaps where many persons tell me, a lot of my patients speak about perhaps home gardens. It's difficult in the urban areas of this country. It's hard in places such as Port of Spain to actually even consider having an urban garden. So if you're growing a garden at home, but it's something to consider. Your fruits, your vegetables, your peas and beans, your grains, towards a healthier lifestyle.
In keeping with what you just said, I read where I'm reading from an article here, World Diabetes Day calls for sugar tax to be implemented, and it was said locally. Medical Director at the Southwest Regional Health Authority, Dr. Albert Prasad, said lawmakers should seriously consider introducing a sugar tax. So I've read that before. My thing is, medical practitioners like yourself, surely you all would be considered or consulted when policy is being formed as it speaks to this sort of thing. Do you all engage as activists in some way in your professional capacity and insist that what you're saying is put into law and regulation? But I've never been to a restaurant in this country where I'm seeing that red, amber, and so on.
Yeah.
I've never seen that.
It's unfortunate. So it's unfortunate, and it's something that would definitely have an impact on health. So I think at some point, so if you attend a restaurant and you see that menu, as we see in the US and Europe, and you see that menu with a number of calories, or you see the risk that you're taking in eating, that it would have some sort of psychological impact in someone's choice. Just as we found that prevention involved wearing seatbelts when you're driving, it's going to prevent death should there be an accident. Just as we saw that banning smoking in public places was going to reduce perhaps the incidence of smoking and indeed the complications associated with it. Sometimes legislation is required to implement some of these changes. Enforcing these sort of changes upon restaurants, ensuring that they perhaps reduce the content of sugar or salt in their foods, because salt indeed is an acquired taste. And they're found in places. Once more, I returned into the UK because I did my postgraduate training there and was involved in some primary prevention studies and strategies while there, that they found that just reducing salt without informing anyone was not associated with a reduced uptake from your patrons in a restaurant. No one was aware. It's an acquired taste. If you stop having salt and pepper shakers at the table, a simple change like that could be associated with positive health effects, including a reduction in blood pressure. So those are simple steps, baby steps that may be implemented by the government. And I agree that the Medical Association needs to be more vocal. The Diabetes Association of Trinidad and Tobago has come to the forefront. They need to be more vocal in embracing this drive towards a healthier Trinidad and Tobago. Because primary prevention, and I'm using that term once more, because I want our listeners to understand that we're not waiting for you to get ill. We're not waiting for complications of these chronic NCTs. We're waiting for you. We are going to prevent it at the level of the health center. We are not waiting for you to arrive into hospital with a devastating complication. We are looking for you at your primary care physician, at the health center. We're screening for complications. We're instituting a healthy lifestyle and ensuring that you're fighting genes and providing an environment for a healthier future for our children.
You know, the attitude to doctors by the man on the street would change and may have changed with time. um, there's a belief that doctors, they make their money in the cure. If people don't get sick, doctors are making the money that they would make. So the more unhealthy we live, the better for the medical profession. Of course, that's a myth. I'm sure that it's that may not be all that's in the thought process, but it's no different from any other profession. I mean, I'm a lawyer, and one of the things that they say to us is, I've heard, not that I put it into practice, I've heard that when the public is fearful, and when you explain to them the dilemma that they're in, that the money is in the fear factor. When people are afraid, they spend their money. That doesn't mean to say that that is the approach that lawyers generally take, but I'm saying that to say, I'm not pounding a doctor, I'm not against doctors.
Sure.
But where I'm at is this. If it is we are treating with the issue of diabetes and non-communicable diseases, then there must be greater education with regard to what are the long, medium, and long-term consequences. It's not just about reducing sugar intake and looking at your calorie intake and managing your diet on that level, but the benefit is that you wouldn't experience certain diseases that are triggered by one's lifestyle. So if you control your lifestyle in your youth, you should have a better end product in your 50s and 60s moving forward.
Well, that is why we have to move away from being just focused on treating an illness. Our goal is prevention. And I agree with you, there is some truth in the fact that, particularly within big pharma, the huge pharmaceutical industries, that it's money driven, it's driven by business. But most of the doctors locally would be interested in getting patients healthy and preventing the complications. When we look at something like diabetes, we mentioned that it's the leading cause of blindness, kidney damage, amputations. You're 2 to 3 times more likely to have a heart attack or stroke. When we talk about hypertension, we're talking about the complications ranging from strokes, blockages to the arteries in your legs, to your heart failure, kidney damage, damage to the back of the eyes. So these are insidious. And what is dangerous about these problems, and this is why we've been alluding to the role of screening and seeing your doctor, despite the fact that in the past we were told that you would wait for an illness or wait for symptoms. At that point, it may be too late. That is why diabetes and hypertension, 2 big NCDs, exploding NCDs in the world, and Trinidad and Tobago is no exception. That is why these are known as silent killers. There is a paucity of symptoms in the early stages. We could talk about some of the signs and symptoms of having a high blood sugar, such as thirst, frequency of urination, weight loss, blurred vision, increased risk of infections. But at that point, your blood sugar levels are extremely elevated. Some persons may find that they're having problems with blood glucose and they have no symptoms until they go to the doctor for an unrelated reason. Perhaps you may go if you've twisted your ankle, if you have a cold, and when he or she checks your sugar, it's extremely high. So screening annually, I would say, particularly in the West Indies, you should consider that from the time you reach the age of 20, persons would want to consider checking sugar, blood pressure, and even your cholesterol. Maybe the frequency at which you would monitor these would vary according to age. Because remember, we spoke about the complexity associated with body weight, and that also applies to a chronic illness such as diabetes or hypertension. It's not just lifestyle, it's genetic, it's socioeconomic, it's cultural and psychological. So we are seeing these illnesses at earlier ages. School children are becoming a diabetic now, and it's not just type 1, they are getting the type of diabetes school children are becoming diabetic and are developing increasing body weight. They're developing the type of diabetes that we used to see in adults over the age of 50. We're seeing this in primary school children. So the value for screening cannot be underemphasized when we're discussing preventing chronic diseases. And so although you may think that it may not be necessary to see a doctor in the absence of symptoms, I would want to say that that is a myth, that you'd want to be having a regular screen, perhaps from the age of 20 or a bit older, according to whether you think that you will be at risk. Persons with a family history, so as I mentioned, so if you have had a history of diabetes when you're pregnant, so if you're Trinidadian, if you're having increasing fat around the tummy, if you have a darkening to your neck, the armpits, around the groin, those are all subtle markers, perhaps, of diabetes. So you'd want to be careful, get your bloods checked, check your blood pressure in the pharmacy or the doctor's office. Many of these health fairs are able to detect abnormalities. Have a chat about your cholesterol, whether or not you need to look at your total, your good and bad types, and embarking on a healthier lifestyle.
In an article that I read, it says here, and I'm quoting, I got this from the Trinidad Guardian. It's an article called Can Diabetes Cause Blindness?
Yes.
It says that according to the Pan American Health Organization, 80% of blindness is avoidable and can be either treated or prevented. The three preventable causes of blindness are cataracts, glaucoma, and diabetic retinopathy. Retinopathy.
Yes.
Could you explain to us what exactly is diabetic retinopathy?
Retinopathy. So diabetes is the leading cause of blindness among working aged persons. I'd like to reiterate that. My wife, Neela, is an ophthalmologist, a surgeon who specializes in problems affecting the eyes. And it is recommended that persons with type 2 diabetes, and that includes 90% of our patients, it's marked by insulin resistance. They have insulin, but there is resistance to circulating levels, and eventually changes to the pancreas, dysfunction to those cells. 90% of patients with type 2 diabetes should be screened for changes to the retina annually, or more frequently if you have these changes. A patient with type 1 diabetes, they have damage to the cells in the pancreas and require injections of insulin for life. And perhaps those persons are screened once a year, 5 years after the diagnosis of type 1 diabetes is made. So think about the eye like a camera. So the front of the camera, you have the surface, you have your lens, you have your clear part of the eye, then you have the jelly-like substance in the eye, and the film in the back of the eye is called the retina, and the images are focused onto there. As a result of high blood sugar, high blood pressure, smoking, and different factors, there will be changes to that film in the eye or the retina in the eye. This may include a reduced blood flow, a reduced level of oxygen. Once more, a host of inflammatory substances are produced, and there may be leakage of blood vessels, leakage of substances out of vessels, sometimes increased blood vessels to the back of the eye. And it's not good because this can often predate blindness. So it's the commonest cause of blindness in working age persons. Retinopathy refers to damage to that film at the back of the eye. Some patients may require laser, sometimes injections to stop these changes and inflammatory mechanisms which are occurring, so as a result of uncontrolled blood sugar or blood pressure, and you may need to then see your ophthalmologist more frequently. So it's one matter to actually see an optometrist or an optician for your glasses or your contact lenses, or perhaps a basic eye screen to check the pressure in the eye. But someone with diabetes, an individual with diabetes, should see an ophthalmologist at least annually. So that's a surgeon or a medical doctor who specializes in diseases affecting the eye. You mentioned about the cataract, and that is also commonly caused by high blood sugars, diabetes, but also is linked with age. It's the commonest operation actually in the world, Fareed, in which the lens becomes cloudy and needs to be replaced by different surgical techniques. Glaucoma is a separate entity, and that is linked to increasing pressure in the eye, damaging the optic nerve, and that is a silent thief of sight. It's common to mention, it's important to mention because it's common in Trinidad and Tobago. It runs in families, particularly in the Afro-Trinidadian. Glaucoma is a silent thief of sight. You may sometimes see some of these articles in the media during World Glaucoma Week, but it's important to know about those three entities affecting the eye. And particularly, we are worried when we discuss diabetic retinopathy and the unfortunate sequelae.
For the listening public, I read before that diabetic retinopathy may not show noticeable symptoms. As the disease worsens, people may experience symptoms such as, and I'm reading here, blurry vision, increased number of floaters, vision that changes between blurry and clear, poor night vision, seeing dark or blank areas in their field of vision, colors appearing faded, and vision loss. That's a lot of symptoms. You know, sometimes I'm reading that and I'm trying to see if I'm experiencing those things.
Those are non-specific. So something like seeing floaters, it may not necessarily indicate retinopathy or changes to the retina associated with diabetes. But that's why it's important to screen with your ophthalmologist.
I've been wearing glasses for the greater part of my life. There's a difference between an optometrist and an ophthalmologist. You have to get I'm saying that for the public, before you can see an ophthalmologist, in my understanding, you have to see an optometrist who gives you a referral letter to go to an ophthalmologist. Or can you just walk in, decide that you want to see an ophthalmologist and they take you right away?
Things have changed now in that we would advise that patients see both, especially someone like you who may have been battling short-sightedness since childhood. Sometimes younger people would be wearing glasses or contact lenses, so they would see an optometrist or perhaps a dispensing optician. And then if there are some subtle abnormalities, you may subsequently be referred to an ophthalmologist. However, if you wish to seek a review by an ophthalmologist directly, that is also available. Your primary care doctor or even those in a health center can even refer directly to an ophthalmology clinic or an eye clinic at the hospitals throughout the country. So you can actually access care from an ophthalmologist in the absence of a referral from an optician or an optometrist.
Right, that's a lot of information you've given us. My concern is I'm with you in the discussion and in your explanation. What is your view in the context of your profession in terms of how reversible is diabetes? Is it something that we can control best through diet and exercise? What are some of the things that we can do to, if you're already there, what can be done to keep it properly managed?
That's a marvelous question, Fareed, because I believe there is a potential for reversibility. And I've seen this in clinical trials around the world, particularly in patients. And once more, we are back to our discussion on the value of screening, particularly on those persons who may be pre-diabetic. So you're standing on the threshold of becoming a full-blown patient with diabetes. So your blood sugar levels have not reached a diagnostic level for diabetes, but their levels are becoming mighty close. So perhaps a fasting blood sugar level of 100 to 125. If you do it randomly or 2 hours after eating, a level of 140 to 199 milligrams per deciliter. If you do a hemoglobin A1C test, so that's a test that looks at your sugar for the preceding 3 months, and it is 5.7 to 6.4%, you would fall under category of pre-diabetes. This is a red flag. It's a wake-up call that intensive lifestyle changes can reverse this progression. There is trouble ahead. Trouble is brewing, but all is not lost in terms of intensive lifestyle interventions with an alteration in your diet and, of course, improvement in your level of physical activity. That also applies to patients who may be newly diagnosed with type 2 diabetes. So just as I mentioned, 90% of our patients may be battling type 2. So it's the commonest type. Type 1 is the type in which, for whatever reason, there's destruction in the cells of the pancreas and patients require insulin. Reversibility is not an issue in this sort of patient. Of course, in the future, we're looking at things like a transplant, or even changes and mechanisms such as a bionic pancreas. And this is on the exciting horizon when we're talking about new technology in diabetes management. But it is eminently reversible, the early stages for type 2 diabetes, when we're talking about weight loss. And once more, it returns to that cardinal pathophysiological problem of obesity. Losing weight, and we have found that you don't have to get down to become as thin as a whip. You don't have to become, you don't have to look unwell and have all of your relatives and friends asking if something is wrong with you. You know, that's part of the cultural aspects that many of our patients battle. If you lose about 10 to 15% of your body weight, so let us say that you weigh 200 pounds and you're diagnosed with diabetes, 10% of 200 is only 20 pounds. You are able to often cut your blood sugar level in half. You may even consider you're on the path to reversing problems like type 2 diabetes and hypertension. So you do not need to get down to 100 pounds. You're weighing 200, 10 to 15% weight loss is associated with a reduction in your blood sugar, your blood pressure and cholesterol, and even reversibility. And that's why, although we say the watchword is prevention, it does not mean that you're cured and you can now become lax and revert to your poor lifestyle habits in terms of lack of exercise and eating what you wish. It just means that you have inculcated positive changes into your lifestyle. And that means you are going to look after yourself so that doctors like me won't have to.
Dr. Tilak Singh, thank you so much for your time. To the listening public, we've had this afternoon consultant in internal medicine, diabetes, and endocrinology, Dr. Joel Tilak Singh, sharing with us. Dr. Tilak Singh, it's been 50 minutes. Thank you so much for sharing this time with us. This is an important introduction. I'm hoping that we can have you again and spend some more time with you on another Wednesday.
You are most welcome. Once more, it has been an honor and a privilege. Blessings to you and your viewers. And indeed, so I have seen one of my mentors will be joining you for the next hour, Dr. Ramuta, and I'm sure that he will be speaking a lot about the burden of cardiovascular disease in this country. Love and blessings to your viewers and indeed to your family, Fareed. Thank you for having me again.
Thank you so much. Thank you again. And we look forward to another occasion with you in the future.
Take care and best wishes.
Same here. Dr. Ramuta, good afternoon.
Hi, good afternoon, Fareed.
Good afternoon. It's such a privilege to have you. To the listening public, again, we're continuing in that series of discussions we've been having on diabetes. And today we have Dr. Pravin Ramuta, specialist in internal medicine and cardiology. Dr. Ramuta, thank you for making yourself available to us this afternoon. What we've been doing is having discussions and inviting the public to listening for an education in how to deal with diabetes and the onset of some of the consequential diseases that may arise out of the members of the public and persons mishandling their condition. Tell us something about the relationship between diabetes and how it can create problems as far taking us as deep into cardiovascular disease. What's that relationship? Because sometimes, the public hear that we need to manage our sugar levels, we need to eat properly, we need to diet, but without knowing what the medium to long-term consequences are, we don't implement those changes in time. And then one day you feel ill, you go to the doctor and you realize, I've had a condition that would have been latent and expanding and growing and evolving inside of me until I experience symptoms that make me feel unwell.
Yes, so thanks very much. Is a very important question because what we are dealing with is silent disease. So in the early stages, you have diabetes, it's silent. You don't feel ill, you move about, your sugars could be a bit high, mildly high, and you're unaware unless you happen to be checking regularly. And the issue with diabetes is that it can affect, as we know, different organs in the body. It can also affect the circulation. Now, the circulation is divided into two main types of vessels, the big vessels and the small vessels. The big vessels are the ones that goes to the brain, the heart, and the legs and the limbs. So, which is why you could get people with heart disease having arteries that are clogged up in the legs, end up with amputations, arteries that are clogged up in the heart, and they end up with heart attack, and then in the brain, and you end up with strokes. But we also know that people with diabetes end up with kidney disease and eye disease. And these are because the diabetes that tend to affect the fine vessels. And that is called microvascular disease, and they tend to affect the kidney and the heart and the eyes. So for the large vessels, however, the presence of diabetes, long-standing diabetes, can contribute to damage to your arteries, and it starts with the development of the blockages, or which we call plaque. And it's because diabetes generally does not exist by itself in patients. Most patients have diabetes in concert with other risk factors for heart disease. Most commonly hypertension, also high cholesterol, and if you smoke cigarettes, that's also one. And then people have genetic factors where, their family members have had heart disease. So all of those things combine in patients, and you get increased um, risk of developing blocked arteries. And when you have blocked arteries, well, the organs being supplied do not work properly, and you can start feeling ill. So with the heart, for instance, the heart may not be able to pump as well as it should, because when you call for more blood supply, because the arteries are blocked up, you get inadequate amount of oxygen and nutrition going to the heart muscles. Similarly, when you walk about, you may get cramps in your feet, or your feet get tired because you're not getting adequate blood supply going down to your leg muscles. And then we know from time to time, you could get blackouts, and you could get various little symptoms that make you feel unwell and unsteady in the head. So the link between diabetes is that diabetes is one of the risk factors that cause clogging of the arteries. The other risk factors, the main one is hypertension, high cholesterol, cigarette smoking, and genetic predisposition, right? So being able to determine if you have diabetes, first of all, by checking and screening, and then if you have symptoms that suggest that you have a problem with your circulation, then going and getting screened to look to see whether you have problems with your peripheral circulation in your legs, or maybe your circulation in your heart, or sometimes you can do a test to check the arteries that go up to your brain in your neck to see if they are clogging there. Hope
I
that
have a,
answers. Yeah.
I have a question. To the listening public out there are a lot of smokers in the public space. When you say that one of the risk factors, and you can correct me if I'm wrong, I'm a lay person, one of the risk factors is cigarette smoking. Is that cigarette smoking to the actual smoker? What about secondary smoke? Is that a risk to persons like myself who don't smoke, but you're in spaces where people smoke and you're smelling it?
Yes. Yes, it is. Passive smoking is also recognized as a risk factor for getting all the complications of smoking. You get it in smaller quantities, but it is a risk factor. So if your spouse smokes and you breathe in the air that he or she exhales, yes, you are being exposed to it as well. In a lower level, but you are still, it is recognized as a risk factor, passive smoking.
I don't want to be controversial, right? But I have to ask, in 2019, the government or the state decentralized, the parliament addressed the issue of marijuana, and they decriminalized
Yes.
small intakes. So if it is you're smoking, if you're in possession of 30 grams of marijuana, unless it is not treated as sufficiently criminal to have you charged and brought before the court, it's still criminal, but you're allowed a certain amount of leeway, if we put it that way. What is your medical position on persons who smoke marijuana? Does that?
So first of all, people who smoke marijuana usually smoke tobacco. So it's very difficult to separate the effect of if the patient does have a problem with his clogged arteries, to what extent it came from marijuana, and to what extent it is as a result of tobacco. However, scientific research has shown that you need fewer cigarettes of marijuana to have the same effect on your clogging of your arteries as as tobacco. So whereas you might be smoking 20 cigarettes a day, tobacco, you might be smoking 4 cigarettes of marijuana. The science is saying nowadays that even if you smoke 2 or 3 cigarettes recreationally, that contributes as well to the risk and may contribute more. For instance, 4 cigarettes of marijuana is potentially more dangerous than 4 cigarettes of tobacco.
Wow. Well, I hope the public is listening to that. When I read of the decriminalization, one of the thought processes I had is whether this is simply for ease of controlling the levels of criminality, and for in terms of reducing the workload of persons charged and brought before the court, not mindful of whether medically it's something that ought to have been done. So in my little position, having heard what you just said, it appears that you solve the problem in one area and creating another problem scientifically, in terms of medically, creating complications, because we may have, as a result of that, let us say more people felt comfortable now to make use of marijuana as of 2019 when that legislation was passed. In 20 to 30 to 40 years from now, it may be
we will be seeing the impact of it. Yes. Yeah.
Wow.
And the thing with marijuana is that very early on, research has shown that within 1 hour of smoking a marijuana cigarette, you have a high risk of something happening to you. It could be accident related. It could be stomach and intestine related. It could also be heart attack related within 1 hour of cigarette smoking. 1 hour can cause a sudden surge in the adrenaline production in your body, which can trigger the heart to beat in a fast, rapid, and irregular fashion. So there is that, and plus during that same 1 hour, your mental status may not be as cogent and coherent as it should be, and you may not take the necessary course of action to preserve your health during that 1 hour.
That is a discussion for another day. Maybe we could evolve that in another discussion. But it's important what you said. I mean, it's quite enlightening. Now, in keeping with what you're describing, you're saying that clogged arteries can lead to you have maybe you can walk us through that microvascular disease and clogged arteries. So you're saying that these blood vessels, if it's clogged and bigger ones are clogged, then we can cause different kinds of problems. So the microvascular may be with the eyes and with I would imagine the tip
kidneys.
of the fingers, the kidneys.
The kidneys, yes.
So let's perhaps we can elaborate on that in terms of when we have microvascular problems. Tell us about some of the problems associated, the diseases or the conditions, the symptoms associated with these diseases and conditions that could be indicative of microvascular disease?
So the two main ones would be your eye disease and your kidney disease. So with your eye disease, diabetics are requested to go and see their eye doctor to have the back of the eye examined at least once a year or maybe every 6 months, depending on the stage of your diabetes. Generally speaking, once you have diabetes for more than 9 years, you have an increased risk of getting damage to the back of the eye, the retina. And very often you don't know because you're not seeing black spots and so on. But sometimes you start to get a black spot in your vision, and that is indicative that at the back of the eye, that part of the retina, that part at the back of the eye that receives the light is damaged and is not able to perceive the light, and instead you perceive a black spot. So there are various stages of eye disease that you can get, and one of the last stages is irreversible damage, where you again get the retina separating from the back of the eye, and that is irreversible. You end up with permanent loss of vision. Cataracts can also occur in people with diabetes, but not due to vascular disease, but due to the effects of the sugar levels circulating in the body. It can affect the lens. With respect to the kidneys are filter, and as you know, in a filter you have very, very fine spaces. So the blood has to go through very, very fine spaces. So you have a network of very fine blood vessels through which the blood is pumped, and because there's a pressure difference, you'll get filtration of fluid out of the blood. That fluid eventually becomes the waste product called the urine. Those very fine blood vessels, they can be damaged by the presence of diabetes, the sugar in the circulation, as well as the pressure that is required to deliver the blood through those very fine blood vessels. And they become leaky because they get damaged. And the very first sign is the presence of increased amounts of protein in the urine. So the filter, generally speaking, if it is working well, does not filter out protein. So there's a very minimal amount of protein that leaks out. But when you have your urine tested and we see that your urine protein level is going up, that's a sign that your kidneys are being affected. And that occurs before your blood test starts to read abnormal. So it's important that that is also be screened, and we recommend that is done every 6 months in a diabetic. I must say that in both cases, blood pressure control is of utmost importance. You could do a very fine job of getting your blood sugars under control, but if your pressures are out of control, the damage done to your small vessels continues. So at that point in time, it is very important that we get our blood pressure under control. And even people who have what we consider a normal blood pressure would be put on medication that people normally recognize to be blood pressure tablets, but they are being put on those tablets with two objectives in mind. One is to keep your pressure down, so it could preserve the filtration membrane in the kidney. And secondly, they can help to reduce the amount of protein that you are spilling in your urine. So drugs, for instance, like enalapril, lisinopril, these are commonly known to be hypertensive drugs, and people very often are put on these drugs by doctors, and they go to the pharmacist, and the pharmacist say, but you don't have high blood pressure, you shouldn't be taking this. There are other reasons why the doctor could put you on those tablets, and in order to preserve your kidneys. They have a protective role in preserving your kidneys. So there are a number of drugs like that. So I just wanted to mention that point. So those are the two main ways. There is, however, the big blood vessels divide and divide and divide, eventually becoming these very small vessels called capillaries. And they're in all vascular systems in the body, even in the heart. So in the heart and in the brain, you have very fine blood vessels. So these blood vessels can also similarly get damaged and diseased. And even though you cannot detect cholesterol plaque in them, the vessels are damaged. The vessels are what we call scarred or sclerosed. And you can see that even though the blood vessel is going up to a certain point, the tissues may not be able to get the oxygen and the nutrition out of it because it's basically like the pipeline has reached a place where it's rusted off. So no more water gets through, no more fluid can get through. So that's another way. The heart patient, somebody can develop a weak heart because the muscles have now become incapacitated because they don't have adequate blood supply, they don't have energy, and there's no large vessel blockage, and patient never reported having a heart attack or has no evidence that the patient actually had a heart attack, which is the large vessel becoming blocked. Their large vessels could be fine, if small, fine vessels could be damaged.
I've heard, like I had a neighbor some years ago, he said that he was functioning with 33% of his heart was functional. And I heard somebody said that another person that 15% of their heart was functional. Is it that when you have vascular disease that it can reduce?
Okay, so let me clarify that, right? So when doctors tell the patient that they have 15% or 25%, it's not that we are telling them that they have 15%. What happens when the heart beats? The heart is a pump, and when it beats, it pumps blood out, but it doesn't empty. So whenever it beats, it is supposed the normal heart will beat 50 to 60% and empty 50 to 60% of the blood with each beat. So when we do something called an echocardiogram, we measure how effective the heart is pumping. That is a measure of how the heart is called the ejection fraction, and that is the number that very often we hear. So somebody with 50 to 60% it can be quite normal and quite healthy and have no symptoms. 35% we'd call that moderate, 15 to 20 call it severe. But it's not that the heart is functioning at 20 to 25%, it's that the ejection, the amount that is ejected out of the heart with each beat is 20 to 25%. It is reduced. But it is not as bad as thinking that out of 100%, you're only functioning at 25%. Yes, the small vessel, as I said, can affect the muscles of the heart, so they don't function well. But more often than not, well, in males especially, it's the large vessels that get blocked. And they get blocked due to the presence of the cholesterol plaque, which develops as you get older. Everybody gets plaque as they get older. People with diabetes, hypertension, cigarette smoking, high cholesterol, and maybe inactivity tend to develop it at an earlier age. And this is why sometimes you see smokers in their 40s, or you have a lot of people who have hypertension and they're overweight, and they have a condition which is called hyperinsulinemia. That means they have high circulating insulin levels, even though they have diabetes. These people are at increased risk of developing this condition where you have cholesterol being deposited in the arteries of your heart, called atherosclerosis. And so with these conditions, you get accelerated or premature blockage of your arteries. So people over the age of 70 or 80, if you look at the arteries, you're likely to see some calcification, likely to see some blockage. People in, younger than 60 having those things, we consider that premature. So the presence of risk factors causes premature heart disease, which we know is very devastating to patients and their relatives. That, you know, you've been diagnosed with heart disease at a young age. You might be impeded in how you're able to function and carry out your work and earn your living, because now your heart is weak or your heart is giving symptoms.
How does one, you mentioned that increased protein levels in one's urine, if I recall, you said it. How does the lay person out there, persons like myself, how do we recognize that there's increased protein level? Is there a home test that you can do, or is there certain things you look for? Like doctors, I've heard doctors say in the past you must look at your urine just to see if there's coloration changes. It might
No,
be a
this,
sign
these are, this is microscopic. You cannot see this with your eye.
okay.
So naked eye, you can't smell it, or you cannot look at the appearance of urine and say it's cloudy. Yes, there are sticks that people can use. Long ago, before we had the blood glucose monitors that people use at home, stick your finger, you put a drop of blood on a strip, and you put it in a machine. We would ask people to test their urine at home, and the sticks, you would put a little stick in the urine, leave it there, and then you observe it for about 2 minutes or 3 minutes, and you compare it against a color change. One of the the test that is done on that, so you can do blood, you can do protein, you can do glucose, you can do ketones. There are several things, but yeah, so they have tests that people can use at home to detect the amount of protein in the urine, right? But that gives you a rough idea. What then you should do is go to a lab and have what we call a spot albumin creatinine ratio done, in which it measures both the creatinine level and the albumin level in the urine, and that gives you a better idea as to the amount of protein you have in your urine.
You know, we live in a highly reactive society. I don't wanna speak for any other place. I only know where I live. In Trinidad and Tobago, people respond to symptoms. You get a chest pain, then you go to the doctor. Is there any sort of preventative care that you could recommend in relation to persons out there who may not be at that point where they're experiencing, if I may put it this way, active or pronounced symptoms, but at least
Right.
some sort of pre-testing
So
heading down that path?
actually, the role of pre-testing is limited in this situation. What by diagnosing you have diabetes, high blood pressure, high cholesterol, it it gives us an idea of what your risk profile is. And there are risk profile calculators that we can use, the your name, your age, your sex, your blood pressure levels, your cholesterol levels, whether you have diabetes, etc. And that gives us an estimate of your range, of your risk. And that risk tells us what is your risk of getting a heart attack or heart disease within the next 10 years. And there are prescriptions of what we can do to prevent. This is called primary prevention, preventing the disease before it occurs. And this is where sometimes we recommend aspirin, we recommend cholesterol tablets, because these have been shown to prevent heart events in somebody who is at risk. Um, the reason I said that is that if you're at low risk, there's no benefit for you to go out and take aspirin. Lots of people are of the view that they should take aspirin just because of diabetes or because they're age 50 or so. There are risks associated with taking any medications, and we have to estimate what is your risk of getting an adverse severe reaction to one of these medications versus your risk of you developing a complication. Yes, so there is an algorithm that we can follow to determine your risk and determine what level of prevention you need to be using. And of course, as you get older, we may need to revise it because as your risk changes as you get older. So we may also look at what level of blood pressure we accept as normal for somebody with diabetes. We accept a lower blood pressure for diabetes. So a non-diabetic person 140 over 90 and above is considered high. For a diabetic person 135 or 85 is and above is considered high. So we would be aiming to keep your blood pressure down, because evidence has shown that by reducing blood pressure levels in a diabetic patient, we can prevent death and we can prevent heart attacks. So yes, so there are things that you can do, which we call primary prevention, preventing the complication before it has occurred, not treating them after they have occurred.
Would exercise and, well, I know everything is about diet and exercise. So many people say that you need to diet, you need to exercise. But I've read where very fit athletes. I read where Iker Casillas, a Spanish football player, and an Argentine player, Aguero, they both suffered
Right.
heart attacks, and these are highly fit athletes who were training from their early pre-teenage years well into their adulthood, and we see so many athletes suffering heart attacks and so on.
Right. So that's a whole different category of heart disease. Yes, heart attacks in those groups of people tend to be related to an overtrained heart, which is what we call hypertrophic. That means the heart is a muscle. If you're overtrained, the muscle gets too big and too muscular. And when the muscle crosses a certain level of thickness, it increases the risk of a number of complications, one of which is to develop abnormal heart rhythm. And so that's why sometimes some of these footballers suddenly collapse on the ground. They can be shocked out of it, or the chest can be compressed and they can come out of it if we terminate the abnormal heart rhythm within a few seconds. But that is because of the risk of having an overtrained heart. So highly trained athletes and people are at risk of developing that sort of heart disease. You can also develop a rupture of the vessel, which is unrelated to having blocked arteries or arteriosclerosis or clogged arteries. The vessel wall can rupture and rip just due to sheer stress and due to the amount of hemodynamic pressures on the circulation. And thirdly, these patients can also have a genetic predisposition to having conduction abnormalities or rhythm abnormalities. These are the three main reasons. So overall, if you look, yes, a few high profile people have developed what is described in the lay media as heart attacks. Very often they are not heart attacks, but they are heart events where somebody drops on the ground, has suffered cardiac arrest. They can be resuscitated and suffer, complications and so on as a result of it. But overall, the risk of getting heart disease as compared to the, the non-athlete person who has the normal risk factors, the risk of getting a heart event in such a person is, on the whole, much lower than the average person. So even though we get, the news sensationalized it, reported, etc., it is not, that should not deter you from doing moderate intensity exercise. Moderate intensity exercise is very low risk, and for the average person, moderate intensity exercise is defined as 150 minutes of cardio activity, running, jogging, cycling, skipping for the week. 150 minutes for the week is described as moderate activity. So if you go on your walk 45 minutes a day, 3 days a week, you would have almost made 150 minutes a week. And the health benefits are quite significant. As we're on this topic, and I heard the tail end of Dr. Tilak Singh's presentation, where he was talking about diabetes and so on. Just like to point out that in Trinidad and Tobago, yes, we like to talk about diet and like to talk about exercise, but 46% of our adult population are classified as having obesity or being overweight, 46%. The estimated prevalence of high blood pressure is about 25 to 26% in our adult population. Diabetes, well, it's about 12% of our adult population have diabetes. The reason is, even though we started talking about diabetes, most of our diabetic patients, if not all, are also likely to be hypertensive. So, because 25%, 26% has hypertension, 12% have diabetes. It's more than likely that you're going to have both of them. And what studies have shown is that, generally speaking, you need to have high blood pressure as a real accelerator to have heart disease. So if you have heart disease, you have diabetes, more than likely you have high blood pressure, which is where diabetics should be screened and aggressively managed for their high blood pressure, because controlling that will significantly reduce your risk of developing heart disease and kidney disease as a result of diabetes. And of course, exercise could help in some way in controlling obesity. And I was hearing your previous speaker talk about you only need to lose 10%. Studies have shown that 95% of the benefits or that you get from weight loss, you actually get it with the first 5 pounds that you lost because you have already changed your profile, you have changed your energy consumption as well as your expenditure profile when you have started to lose weight. And once you start to exercise, what you do is you start putting on muscle mass. You may burn off some fat, but you put on muscle mass because now you're using the muscles more. So your weight may not change much significantly in the first month. You might remain the same weight, but the profile is now healthier because now you have more muscle mass and less fat mass, and the fat is also distributed away from the abdomen. The abdominal fat or visceral fat is what is associated with the increased risk of developing atherosclerosis or clogged arteries because they are the ones associated with the high circulating insulin levels. So even though you may not lose the weight or drop down or get down to whatever is described for you as your ideal body weight, the fact that you have lost 5 pounds or 5%, or you've just started the program means you have already changed your metabolic profile and your risk is already coming down. So it's well worth doing that 150 minutes a week.
45 minutes of walking 3 times a week should take us within that 150 minutes of
that takes it 135 minutes. So you just need 15 minutes again on a 4th day, and you would get 150 minutes in.
What about this is just by way of information for people who don't like to walk and they swim or
Yeah, so that's
the best form of exercise. How do you relate swimming into that?
That's fine. Swimming is also equated as a cardiovascular form of exercise. So yes, swimming, riding, jogging, all of those, rowing machine, all of those will count. Yes. It's also important to do some resistance exercises and some stretching exercises. Resistance exercises are also quite good for your bones and your bone health.
What is it just now? This is again, I'm just asking, is there a gestation period or projected gestation period between out of let me put this, diabetes that is on, let's say, newly onset diabetes, where you see it you're now beginning to experience the symptoms, getting into that you've been diagnosed diabetic. What's the time frame it normally takes for one to digress into or for the condition to result or cause or trigger cardiovascular problems?
So the question is a very good question. Usually, before you become diagnosed with diabetes, it is estimated that the condition was present for about 10 years. It has been present for at least 8 to 9 years, almost 10 years in your system, and your system was struggling all the time to maintain your blood sugars. So you would have been going and having your sugars tested and they come back normal and you feel well fine. How does that happen is that in order to keep your sugars under control, your body is making higher and higher amounts of insulin to keep your sugar levels down. When your sugar level starts to go up, it's now because your body is now failing and struggling. Your body is no longer able to produce that high amount of insulin necessary to keep your sugar within the normal range. And that is the thing is that from that point on, if you're going to measure that you have diabetes, you see you've already been exposed to hyperinsulinemia or high insulin levels for about 10 years. Generally speaking, the magic figure is about 9 to 10 years. So if you don't get kidney disease unless you have had diabetes for about 9 to 10 years. If you get somebody with kidney disease after 2 to 3 years, it is likely that they may have had, they would have had the diabetes and or been unaware and undiagnosed, and that's how we ended up meeting you in this situation now where you have it.
Wow. When we when you look at the average person, I'm being practical here. The average person, we don't live a life where the lay person, he's going to wake up in the morning, let's say at 6 o'clock, he's going to jog, exercise for half an hour, then have a light, balanced breakfast and so on. And then you begin work at 8, and then you have lunch at 11, and you have tea at 3, and at 5 you finish work and you exercise for 45 minutes. That's impractical. It takes a very disciplined person to regulate your day like that. For professional people and other persons, you may have 16-hour days where you get to work at 8 in the morning, 9 in the morning, and you're there until 6, 7 o'clock in the night. Then when you get home, you drive home, you're tired, you lie down, you fall asleep, you wake up at midnight and eat something. And that is just a very simplistic thing. It's probably worse in terms of the day. So you skip breakfast altogether. You get to work, you probably get straight into your routine. You eat at 11 o'clock because you start feeling a bit weakened. How would you as a doctor, how
So
would you
what you are
address
saying
that
is
situation?
very relevant, and we know that it's very hard for people to adjust their lifestyle because, well, they live a particular way because they have to, their career and family life and all that puts demands on them. As I said, life gets in the way. Well, what we ask people to do is small steps, right? So 150 minutes a week can be broken up to 10 minutes in the morning or 5 minutes in the evening and that sort of thing. And then you could go out on a Saturday and do a sweat. We also ask people to make small steps. Small steps means if every day you walk a little bit longer, or you take the steps instead of the elevator, that way you build into your life a little bit more activity. So those small steps, they add up. So for instance, using steps and walking, and they might advise, if you even park your car 50 feet away and you walk 50 feet in the morning to your office and 15 minutes, you're still getting 100 feet more for the day. So these small steps add up, and then during the daytime, you get up and you move about and you stretch rather than sitting all day by your desk and that sort of thing. And if your job involves moving about, um, that also counts for activity that you do. So if your occupation is a farmer or you're a vendor and your job involves moving about, moving on your feet up and down, those also count for activity. So then if you're getting the level of activity, then what you also need to look at your energy input, how much you are taking and how much you're consuming. And you could now try to balance off what you are able to burn off by and with by how much you are taking. So you should try to end up with a negative balance. So every day, because very often you go to do exercise, you get a little tired, etc. But then to feel better, you end up taking like an energy drink, or you take something that replaces back the energy that goes into your system.
I know what your area of specialty is cardiovascular, but at the same time, you should be able to advise us with regard to how significant is meeting meal targets, meaning having breakfast, having lunch, and having dinner at specific times. Because what you described is, yes, we can get in the exercise and the walks and so on to do what is necessary. But in terms of having meals at specific times, does that add value to, or
The,
persons who persistently miss it, are you at more risk?
well, the significant thing is that overall the amount of calories you take in for the day is what matters, right? However, if you take your calories in small amounts, your body is able to handle it better than if you take a single large meal. So people who miss meals tend to overeat in the next meal. So you might be busy at lunch, but when you go home in the evening time, you have a big, heavy dinner. The fact is that because your body doesn't have the ability to handle that amount of calories, because it requires a big effort on the body to produce all the insulin and that sort of thing, you end up having spikes in your blood sugar if you eat a big meal, if you overeat. So the value of having small regular meals is that you'll get the same amount of calories in without the expense of having spikes in your blood sugar. So that is the way they value it. But overall, scientifically, overall, what the amount of calories you take in for the day is what matters. So if you're on a 1500 calorie or 1600 calorie diet and you break it up, that is better than having no food. Some people do intermittent fasting where they eat only all the food they eat within a 6 hour period, 8 period, and eat nothing afterwards. And people claim that that helps with the weight loss, and it may help with the weight loss because once you're fasting, then you are using up what you have stored inside. But if during that period where you are when you are eating, you take large amounts of calories in, your body has to deal with those in a short space of period. Within the next 2 to 3 hours after you eat, that's going to be absorbed, get into your bloodstream, and then your body has to fight to maintain your sugar levels within the normal range.
What we're describing,
I hope that answers your question.
you certainly did. You certainly did. What you're describing, it's good information for adults who have already developed, life practices. What is your recommendation for persons with teenage children who you don't want them to have to find themselves in difficulty in their 20s or their 30s? So you want them to cultivate certain habits very early to avoid the problems that an adult may already be experiencing. Is there any sort of preventative care that one can engage in with your teenage children now to set things in place?
It's yeah, I understand the question. So with teenage children, and this should actually start before teenage years, right? Inculcate into them the value associated with different types of carbohydrates. It's easy to take bread and the white rice and the white flour and so on that is easily absorbed and gets into your blood sugar quickly. It's easy to get snacks that gets into your blood sugar quickly, and you feel high, and you feel lively, and you have that kick of energy. But in the long run, they can be habit forming. You can get sort of like a food addiction to these types of foods because of the way they make you feel good. The complex carbohydrates, the ground provisions, etc., which have a lot more fiber, it slows the absorption of the carbohydrate into your body. So you don't have these big, large spikes of sugar going into your bloodstream. Like if you have a glass of soft drink, that gets absorbed very quickly, your blood sugar goes up, and then it crashes down because once it's finished absorbing, then the blood sugar starts to fall. When the sugar starts to fall, and if it falls rapidly, you get hungry and you crave for something. So then that form of eating easy, rapid to absorb carbohydrate causes snacking again and again. And well, of course, every time the sugar goes up, you feel good, you feel healthy, you feel cheerful. They can be addictive. So getting them to get accustomed to eating more of the complex carbohydrates, nuts, fruits, vegetables. These are the types of diets that have been shown in Mediterranean countries, for instance, to be associated with a low incidence of diabetes, as well as exercise, because kids nowadays like to sit a long time behind the computer or playing a game or on their laptop, and that type of activity, especially because that's how kids socialize nowadays. they need to practice getting a break away from it and practice getting some more physical activity in. So those are the ways that we can do it. In terms of what the Americans did some years ago is that they actually introduced a program in school where called Small Steps, where they wanted to reduce the incidence of, the target was to reduce the incidence of diabetes. And they started making the children walk for 6 minutes a day additional every day. Just make them walk for 6 minutes. And they found that they reduced the amount of diabetes, new incidence of diabetes among children, just by making them walk a little bit longer. So small steps, just like making the children do a little bit more activity, can help to prevent them from becoming diabetic. So, but I'm getting them away from, these highly processed foods that we now know are associated with the increased risk of cancer because of the preservatives, etc., used in the processing, the processes used to preserve these foods. So we should try to avoid giving them those foods and use more of the fruits, vegetables, and nuts, and the complex carbohydrates, and not the easy to absorb carbohydrates like the white rice, white flour.
In Trinidad and Tobago, we have what we call the hunting season, where you people hunt for wild meat. This wild meat culture that we have here, can you speak to how much of a risk it is to be consuming large amounts of wild meat or wild meat generally? Does that put us at a higher predisposition to develop vascular disease or cardiovascular?
I don't think so, because it's animal fat. It contains the same amount of animal fat and cholesterol than other forms of animal of other animal products. As a matter of fact, because it's not processed and it doesn't have the kind of preservative, I don't think it puts you at increased risk because we may choose to eat the wild meat as opposed to the domesticated animals. I don't think so. And I don't believe we eat a hell of a lot anyway during during that period.
Well, it's important that you say that because I was of the mistaken view that you are at a higher risk of of damaging yourself eating wild meat. But if you're saying that it's healthy, well, I'll take it from you.
Well, I don't think it is any more unhealthy than other forms of meat, red meat in particular. And remember, the meat that is associated with the increased risk is the red meats and the processed meats.
All right.
White meats are considered to be better. White meat and the seafoods.
Would you say that diets, and let me give you an example, a typical Trini diet, people talk about all the time, it's Sunday you eat 2 sets of meat, let's say chicken and lamb, and you eat macaroni pie, callaloo, red bean, lentil peas, and the works, potato salad, and people eat large amounts of that week in, week out. Is there a correlationship between some of the problems that we've been having or persons with cardiovascular disease and that amount of food intake per week? Is it a diet that one can recommend or one it's tragic?
In any sort of diet, you allow a cheat day. It looks like Sunday is the cheat day, where you might be working hard and being busy during the week, etc. But Sunday is the day when you allow yourself to go. Now, the issues with having a variety of food is really the total calorie consumption that you take in on the Sunday. So you'll find that people might be well controlled with their blood pressures and their blood sugars and so on, and then Monday morning they're out of control. And that is the issue that we need to be thinking. You're allowed to have your foods. We are not banning any foods. Long ago, you used to say, you can't eat rice, you can't that. You're allowed to eat anything you want, but in reasonable quantities. And that is where I think that, your portions that you take, your portion sizes are important.
All right. To the listening public, we've had Dr. Pravin Ramuta, specialist in internal medicine and cardiology, with us this afternoon. he's been sharing some of his wisdom and his knowledge from his practice through the years and some of the experiences that he's had. Dr. Ramuta, we want to thank you for taking the time for sharing with us this afternoon. The information that you imparted indeed was very helpful. I'm hoping that we can maintain a relationship with you in terms of you making a second appearance in the future, and maybe we can elaborate a bit more. We've got to that point of 6 o'clock at this time.
Thank you. It will be my pleasure to answer the question and to discuss it. Yes, it will be my pleasure in future.
So enjoy the rest of the evening and blessings to you and your family. Thank you so much.
You're welcome.
Thanks again. David, we're back in your hands in terms of the listening public. We've had another Wednesday program of discussing diabetes and some of the effects and what ought to be done in order to prevent some of the dire consequences that we live with on a day-to-day basis. Thank you again and enjoy the rest of the evening.
Okay, thank you, Fareed, and thank you to your special guests. That was Hard Talk with Fareed Ali on Wednesday. Fareed will be back next Wednesday for another edition of Hard Talk.
The future of talk is here. Power 102 Digital.